it's my pleasure to introduce Michael Lunzer, Chief Executive Officer with Itiliti Health, and Keith Brick, Interoperability Architect, also with Itiliti Health, for our technical overview of CMS 0057.
Good afternoon. Thank you very much for the introduction. We're excited to talk with you today about CMS 0057F and really focusing in on a technical overview for the prior authorization API components of 0057F. My name is Michael Lunzer. I'm the CEO and founder of Itiliti Health. I actually came from inside of Blue Cross Blue Shield of Minnesota a number of years ago, and Itiliti Health was founded inside that environment, really focusing in on understanding the needs of payers and how we can improve the relationship between payers and providers. With me here today is Keith Brick. I'll let him introduce himself as well. Keith?
Thank you, Michael. Reporting live from the heart of the Epic Deep Space Auditorium. I'm here at the Epic Developer Conference, helping not only Epic, but all of the organizations that use Epic understand how TEFCA is going to make this prior authorization workflow easier. And I'm stepping away from that conference to help everybody on this call understand that this technology benefits the providers just as much as it benefits the payers. And it's easy to set up. And with the help of the states, we can make it so that the state programs are standardized, easy to implement, and according to those metrics, it's really important that we are able to turn around fast answers, so that we're going to make it easy to get back a fast answer too. So thank you, Michael.
So to start with, we'd just like to frame up what are the specific questions we're going to answer today. So first of all, what are the technical requirements for compliance of CMS 0057 prior authorizations? What are some of the necessary transformations that will need to take place to meet that requirement? How does this impact state Medicaid organizations? And then what are some of the opportunities from CMS 0057? So first of all, just some very basic information. Of course, prior authorization seems pretty straightforward. A provider needs to know whether or not a prior authorization is required, and then they need to know, what do we need to submit and how do we get this prior authorization approved? And many of those details are very specifically oriented towards the patient's health plan that they have in place. So answering these questions about the patient-specific health plan can be fairly challenging. First of all, is prior auth required? Can be buried in various systems at the health plan or at the state Medicaid organization. What data does the policy need, the medical policy requirements? Within state Medicaid organizations, that information is often buried in provider manuals. And then, is it approved? That's just a mechanism that needs to be in place to allow for an answer to be submitted back to the payer, to the provider. So in terms of CMS 0057 and prior authorization, it provides a great structure that organizes this series of transactions to give payers and providers a good method of communication. So the first of those transactions is what's called the coverage requirements discovery transaction. And that is essentially there to help the provider to know, does it require a prior authorization? The second transaction that's part of 0057 is the documents, templates, and rules transaction, which is essentially intended to help answer the question, what data does the the payer's policy need to be sent back in order to get an approval? It can go much deeper than that, and we'll talk more about how questionnaires impact this particular transaction. And then the last transaction that's a part of the API requirements is prior authorization submission, or PAS. And that's the submission of the prior auth electronically and the ability to answer the question, is it approved? And are there additional pieces of information that the payer needs in this case? One of the real big challenges here is that today, many of the document systems that are in place don't meet or can't meet these requirements. So many organizations have spreadsheets or other static documents that providers can refer to answer the question, is prior auth required? Oftentimes, those static documents don't cover many of the various carve-outs or unique cases, and they're very high level. Next, in terms of what data, what policy data is needed, what data is needed in order to meet that requirement, that information is often buried deep in provider manuals within state Medicaid organizations. Within typical health plans, they oftentimes have medical policies that address these questions, but those often are also buried in a PDF and a data store or a Word document. And those, of course, are not a great way to automate transactions. Lastly, is it approved? In that case, the payer, the Medicaid organization needs some method to receive that information and hopefully automate some of the answers to those questions. And so again, in order to facilitate these transactions, there are some key elements that payers, Medicaid organizations need to implement in order to facilitate this automation. First of all, there needs to be some method of documenting these rules in a structured database that can take in an electronic request for is a prior auth required and answer that accurately. Similarly, the medical policy information or the provider manual needs to be essentially ingested into a system that carves out and restructures that data into a scenario where when that provider submits this request to say, what do I need to submit? There's the ability for that medical policy system to answer back very specifically in the context of the specific requested transaction. And then, of course, the payer needs some method of receiving that prior authorization submission and answering those questions. When we think about what the technical architecture looks like, this expands that picture a bit, and I'll just walk through it briefly. On the left side, the provider interface to these new prior authorization transactions can be built into their electronic medical record system. And HTI 4, which has recently been finalized, requires those EMR systems to ultimately support these transactions natively. Another option for the provider is to use a Smart on Fire application or some method of application that interfaces to these transactions. In the middle, we have some method of connecting the provider to the payer. As Keith alluded to, TEFCA and the QHIN organizations will be a wonderful way for those connections to be facilitated. There are other methods of connections that are also acceptable. Providers can directly connect to payers, and there can be various proprietary multi-party connection mechanisms, all of which need to be essentially supporting FHIR. The next entity in this diagram is the FHIR server. Many providers and payers have some method of connecting each other via FHIR and utilize an interoperability server to facilitate that function. This is a great way for payers to have a digital front door to their organization. Next up, you have at the top of this diagram on the right, the CRD or prior auth rules source of truth. Again, that coverage requirements discovery, which is the CRD transaction that comes from the provider, needs some type of system at the payer to be able to automate that answer. Does it require prior authorization? That system also needs to know about any delegated vendors or remote guidelines that might be in place as well. Next up is the DTR, or Documents, Templates, and Rules database. This system needs to be able to respond back to the provider, again, with that medical policy information, specifically a questionnaire, and we'll talk more about that in a minute, that helps the provider to know what to submit, answer various questions, can also automate the answer to those questions inside the EMR to streamline this process. Lastly, is the PAS capability, and there needs to be some mechanism to receive that prior authorization submission and automate the decisions based upon the rules and the questions that were in that documents, templates, and rules questionnaire. Connected to those systems can also be the utilization management system. That's typically more of the case management status kind of information, so that when a prior authorization is submitted, it has a case number. Humans that need to touch those prior authorizations can also interact with those prior auths that are submitted. In some cases, you'll find elements of the things on the right kind of combined together in various vendors' systems. But again, they're all very specialized capabilities. Just a quick nod to how Itiliti Health fits into this picture. We have a product on the right that you see that's called PA Checkpoint Database. That's essentially that is auth required database. Policy management database, which is where those questionnaires and policies can be generated, and then auto authorization and clinical assistant. So getting a little more granular, some of the key elements within this coverage requirements discovery. Again, this needs to be a transactional system that can respond to that is authorization required request. And the data that's going to come to the payer from the provider includes information about the patient, the ordering provider, performing provider, procedure codes, and also information about the patient's healthcare policy, their health insurance policy, that hopefully that payer can cross-reference to understand very specifically what that patient's specific coverage is in order to answer that question, does it require a prior authorization?
Oh, Michael, this is a great spot to answer Teresa and Kimberly's question about what happens when we need to give a fast answer to is prior auth required, or respond to a submission with a status of approved or denied. What are the other statuses that we can use? Well, during the CRD process, we can say prior authorization is required, it's not required, it might be required under certain conditions, needs information, or it's satisfied. And the satisfied status is really cool. It's one of those statuses that allow us to say, you've submitted all of the information that we need. You've told us the performing location, the performing date. You've given us the procedure code and the patient's diagnoses. Maybe we've used the FHIR authorization access token to go and pull a specific piece of background information that we needed to approve that prior auth. And now we've done that for you instantaneously. That's the satisfied status that we can use during CRD to indicate that prior authorization has been approved immediately. When we get a little bit further on, we can do a similar thing during the prior authorization submission by responding with the status of pending and indicate what additional information is needed. Back to you, Michael.
Thank you, Keith. And again, we're moving a little fast here because there's a lot of material to cover. But again, happy to answer additional questions offline as well. So in terms of the DTR, the provider sends over a bundle of information similar to the CRD request that says, what exactly do we need to submit? The payer's response back includes one or more questionnaires that are relevant to the procedures that have been requested, as well as, in some cases, codes that can be associated to questions within the questionnaires, which essentially, when received by the EMR, these questionnaires, if they have enough information, including those codes, the EMR can automatically fill in the answer to those questions. Ultimately, that's the long-term vision for how these questionnaires will want to be structured, is in such a way as the EMR will be able to automate the answers to as many questions as possible. There's a transformational process that will take place that will take some time for payers to convert their criteria into questionnaires, and then eventually add value sets to those questionnaires that allow them to be automated. And there's a evolution of EMR systems, which will allow them to fill in all of that information in those codified questions. In that interim period of time, there are definitely some things that will need to evolve. oops, I hit the wrong button. I knew I was confused by my slides. Sorry. So this is an example of a questionnaire that can be generated from a medical policy and its associated criteria. Again, some of these questions may be able to be automatically answered within the EMR. Some of the questions might have codes that allow that automation. For instance, when there's a document that's needed to be attached, there can be a LOINC code that's associated, so that essentially the goal, of course, is to get it to the point where this questionnaire can be automatically answered on the EMR. An interim step, however, is if these questions are answered by a human that effectively meets the requirements. The goal then, of course, is for that question, that submitted prior authorization, to be able to be answered immediately by the payer in a positive way. The last element is that PAS submission capability. And so when the provider submits their prior authorization submission, they include a number of pieces of information about the patient, as well as all of their questionnaire responses and any associated elements. And from there, the payer can respond back with an answer. Again, as Keith mentioned, approved, pended, or denied. And this allows the provider to get an immediate answer, as well as to be able to continually be updated as this system and process continues at the payer organization. So I'm going to transition now a little bit from what is the CMS requirement for prior authorization APIs to some of the more detailed information about what are some of the opportunities for state Medicaid organizations. So states with non-managed Medicaid should, of course, anticipate the ability to support the full capabilities of the EPA requirements. So CRD, DTR, and PASS. States with managed Medicaid have a tremendous opportunity to improve their state's overall efficiency with prior authorization. What we have found again is that state Medicaid organizations have provider manuals, which oftentimes are documents with hundreds of pages that might have a table of contents that's easy to navigate, that gets a person to the specific requirements for a particular category. But again, those documents are not going to be able to support the requirement of that DTR, being able to clearly and quickly identify, if a prior authorization is required, what needs to be submitted, what questions need to be answered in order to get that prior authorization processed quickly. So
and Michael,
again,
that's a very hot topic here at the developer conference, is that Epic customers are asking, how can we satisfy those prior authorization requirements if all we have from the state is a PDF? If it's a 200-page PDF provider manual, it's not computable. So what we would love to help you do is digitize your policies and provider manuals so that those requirements are machine readable, and so that the EHR, Epic, and everybody else can provide those documents immediately upon request. You can put it directly into that prior authorization submission and deliver it electronically, so that we can get rid of those faxes. We can get rid of the manual processes that are costing so much money today.
And just a little bit of an aside on that, Itiliti Health is currently working with Medicaid managed care organizations, and many of them are working, some of them, I should say, are working to ingest and convert Medicaid provider manuals and convert them into these medical policy structures. And that's, of course, very inefficient, because at the source, you've created these documents, and now the state Medicaid managed care organizations have to go in and one by one convert these documents. And each of the managed Medicaid organizations will also need to do this. So it's a scenario where there's one document from you, and many payers are converting those documents at the same time with the same outcome. So is there this great opportunity for you to help them? So one specific thing I wanted to talk about questionnaires, because that's essentially the essence of that DTR transaction. And that's the need to convert the criteria that are buried in that provider manual and the specific policy into an API compliant questionnaire. And again, I showed you a questionnaire example a few minutes ago. That FHIR questionnaire, I think there's been some misperception of what is a FHIR questionnaire. A FHIR questionnaire essentially is a method of requesting provider information. It does not mean everything has to be in the form of a question as a Jeopardy contest question. It can be yes or no questions. It can be text entry questions. It can be clinical measurement questions like what is the patient's BMI? And it can be document attachment requests. And as I mentioned earlier, some of these questions can have codes associated with them that will allow the EHR to automatically answer the questions. Again, we see that as an evolutionary process because it's a big task for the payer or the state Medicaid organization to convert their policies or their criteria questions into scenarios where every question has a code. And then even if the state organizations or the payers convert all of their questionnaires into coded, all questions being coded, the EHR systems will not necessarily be able to answer all of those coded questions as EHR organizations come up to speed on this capability. So this will be an evolutionary process. But how do we get from where we are to at least the first step of that evolution? We mentioned just briefly that Medicaid organizations, state Medicaid organizations, create provider manuals. Typically, those manuals are created by a work group writing up a policy or a document in Word. Then there's a process of getting that approved and then somehow merging it together into the provider manual and deploying that on the public website. There's some big challenges with this in terms of tracking versions, effective dates of changes, approvals, maintaining auditability and the ability to go back in time and know what was the policy at a certain point, not to mention the inefficiencies of taking Word documents and giving them to a website deployment team and having to manage those things manually. And then lastly, this type of a process creates a really big challenge for the payer and the provider in finding the policy that applies to a particular code or condition. So there's this great opportunity for states to kind of redesign the process. Itiliti Health has a tool. I'm sure there are other ways that you can redesign this process. Ultimately, what you need to strive for is a system that allows you to edit and create and edit these policies as discrete entities down to the procedure code that allow a system to quickly retrieve what is the policy and the data questionnaire that refers to a specific procedure code or procedure. So again, what we have here is a scenario where your policy team uses a system that allows them to interact with the policy and the provider manual that then can dynamically create the full provider manual as well as allow providers and payers to find specific sections of the provider manual and have that system support the machine readable requirements for questionnaires that can be quickly sourced based upon the data in the transaction that says what questionnaire is required and have that questionnaire come over in a unified format. So just a couple of screenshots from what that means and looks like within a system. This happens to be Itiliti Health System, and I'm showing Blue Cross Blue Shield of Alabama's experience with this system. So within their public website, if you go to look for a policy, and you can do that search by procedure code, keyword, date effective, etc., it will find the exact policy and it will show the user what that policy looks like for that specific element. What's happening in the background when it's pulling up that policy is it's actually dynamically assembling this document from the various entities that are a part of that policy. So we have questionnaires and criteria and other content and attachments. All of that, again, is separately distinct data-based elements within policy management system and then dynamically assembled to make it look exactly like the policy or the provider manual looks like today, but with tools that make the revisions and the management of this data very efficient for the policy management team. From this initial ingestion of a policy, we ingest policies automatically to create these separate buckets of information. We then give the policy manager the ability to look just at the criteria section of that policy and have it automatically converted from text-oriented procedure criteria into what we call a JSON or a more codified method where you see the and the or and the other rules automatically represented. And within the database, they're actually separate and distinct items. So now from this document, we can immediately create the questionnaire that represents the same criteria in a more questionnaire-oriented fashion, which can be sent over to the electronic medical record system, and then the user, the provider user, sees this questionnaire in a way that allows it to be filled out, allows the EMR to automatically fill it out, and therefore prior authorization is extremely quickly supported. This is just an example of what that code looks like that is sent over to the provider system. And again, this code is automatically generated based upon the ingestion of the health plan or the Medicaid organization's criteria, and then automatically created. By the way, our system does not use AI to do this. It uses very intelligent rules-based capabilities, and that's really important. So I'm just going to close with a couple of key slides and then see if there are have a couple of questions we can answer. Again, just a little bit about Itiliti Health. We were started within Blue Cross Blue Shield of Minnesota. Our foundation and focus of our company is codifying rules and policies powering human-readable and machine-readable interactions. We have 5 years experience digitizing rules and policies for multiple health plans, which has gotten us a lot of credibility from various consulting organizations. We have a suite of products that not only codify these rules, but also can automate the decision-making. And then lastly, we have a blue chip suite of customers that have been using our solutions for many years, which is what puts us in a really unique position. These tools that we have can be utilized to power the CMS compliant APIs, but also the legacy web and other systems that payers utilize. So our customers have been using us to power their public website, ISAUTH required, and policy management capabilities for many years, and now can just turn on that application programming interface for CMS. So with that, I'm going to pause for questions. I know we're right up against time, but if the WEDI organization can kind of give us any thoughts on questions we can answer now, or again, we'd be happy to answer questions offline.
Sure. Thank you, Michael. Thank you, Keith. There is a question in the chat. What is the maintenance effort for states once the provider manuals are converted to a digital machine-readable format?
Yeah, that's one of the really exciting concepts that we've created here, is that the maintenance of this is essentially goes back to the point where when you're making a change to a policy, you make that change natively inside of the tool. So you're not having to create policies in Microsoft Word. If you want to export them to Word so you can send them to people, you can, or your creative and approval personnel can log directly into the system. And instead of having to modify an entire policy when a disclaimer changes or there's one particular rule change, they can go in and make just that one rule change, create a new version of that policy, and put a date, an effective date on that policy, and save it. Once that's been approved, it's automatically available through the various transparency mechanisms of the public website or the machine-readable artifacts for the DTR.
Excellent. And the final question we'll take right now before we move on to our next session. What are the reporting capabilities of your policy engine?
Yes, the policy engine is extremely powerful. We track every change, who makes every change. We know the effective date of new policies and changes so that we can easily make it possible for a user to go find the policy that applies to their transaction, whether that's a provider or even a state Medicaid member, to be able to go look at what is the policy that applies, what are the rules that the provider is going to be following in order to get that prior auth approved, and then what do I need to submit in order to perform that. So that transactional interface allows you to report on any of these metrics and makes all of this information transparent to providers, payers, and members to the level that the organization wishes to make that information transparent.
Excellent. Thank you very much. Hopefully you can stick around for a couple of minutes while folks may have questions in the chat. But once again, thank you to Michael Lunzer and Keith Brick with Itiliti, and thank you to Itiliti for sponsoring our state Medicaid event today.